Bilateral leg swelling is one of the most common complaints I see, but not all swelling is the same. In this video, I'll show you exactly how I approach it step by step, so you can quickly pinpoint the cause and treat it effectively. When evaluating a patient with lower extremity edema, always consider the underlying imbalance between hydrostatic and oncotic pressures within the venous system as a key pathophysiologic mechanism. Elevated hydrostatic pressure may arise from venous hypertension, commonly due to right-sided heart failure or chronic venous insufficiency. Reduced oncotic pressure is often caused by conditions such as nephrotic syndrome, liver failure, or protein energy malnutrition. Additionally, edema can result from increased capillary permeability or vasodilation, as seen with warm ambient temperatures, inflammatory states like cellulitis, or thermal injuries such as burns. Here's a 68-year-old female presents to the clinic with bilateral lower leg swelling that has been gradually worsening over the past year. She reports that the swelling worsens throughout the day, especially after prolonged standing, and improves overnight with leg elevation. She denies shortness of breath, chest pain, or orthopnea. Her past medical history includes hypertension and obesity. On physical examination, there is 2 plus pitting edema on both lower legs, hyperpigmentation over the medial malleoli, and small varicosities. Her heart and lung exams are unremarkable. Jugular venous pressure is normal. There is no ascites or hepatosplenomegaly. Which of the following is the most likely cause of this patient's edema? A. Congestive heart failure. B. Chronic kidney disease. C. Chronic venous insufficiency. D. Nephrotic syndrome. Or E. Liver cirrhosis. The correct answer is C. Chronic venous insufficiency. This patient presents with chronic bilateral lower extremity edema that worsens with prolonged standing and improves with leg elevation. These are classic signs of chronic venous insufficiency. Additional supporting features include pitting edema and hyperpigmentation over the medial ankles, which are hemosiderin deposition, as well as varicosities. Chronic venous insufficiency occurs due to valvular incompetence in the deep or superficial veins, leading to venous hypertension and fluid leakage into the interstitial space. CHF typically presents with bilateral edema, but would be also associated with elevated JVP, dyspnea, and other signs of volume overload. CKD may cause edema, but it is usually associated with other systemic signs and laboratory abnormalities. Nephrotic syndrome causes proteinuria, hypoalbuminemia, and generalized edema, including periorbital swelling, not related in this case. Cirrhosis leads to hypoalbuminemia and portal hypertension, causing ascites and peripheral edema, often with other stigmata of liver disease, again, not related to this case presentation. Chronic venous insufficiency is a condition in which the veins of the lower extremities fail to return blood efficiently to the heart, leading to venous hypertension, which is the most common underlying cause. This elevated pressure is usually due to valvular incompetence within the deep or superficial veins, resulting in blood poolings in the legs. Patients with chronic venous insufficiency often reports aching, heaviness, itching, swelling, and pain in the legs, symptoms that worsen with prolonged standing and improves with leg elevation. Physical findings also includes edema of the lower legs as well as dilated veins, including varicosities and telangiectasias. There are also skin changes, such as thin, shiny skin or hyperpigmentation. Venous stasis ulcers are also seen, but associated with advanced disease. Chronic venous insufficiency is, of course, a clinical diagnosis based on history and physical exam. However, order a venous duplex Doppler ultrasonography if the diagnosis is uncertain. Also, if you want to evaluate the venous reflux, or if there's planning for possible procedural intervention. Conservative treatment is the mainstay and includes leg elevation, regular exercise, lifestyle changes, including weight loss, as well as compression therapy with stockings, typically 20 to 50 millimeters per mercury, tailored to disease severity. Additional strategies include skin care, which includes daily moisturization that can prevent skin breakdown and secondary infections. And if the patient presents with stasis dermatitis, consider topical corticosteroids, but make sure to use sparingly to reduce the inflammation. Here's a 34-year-old man presents to the clinic with progressively worsening swelling in both legs over the past 2 weeks. He denies chest pain, shortness of breath, or recent travel. He reports generalized fatigue and recently noticed that his urine appears foamy. His past medical history is unremarkable. On exam, his blood pressure is 142/88, and there is a 3+ pitting edema on both lower extremities up to the knees. No jugular venous distension or pulmonary crackles noted. Lab studies show a serum creatinine of 1.0, a serum albumin of 2.1, which is low, a total cholesterol of 280, which is high, and the urinalysis shows a +4 protein, but no hematuria, and a spot urine protein to creatinine ratio of 5.8. Which of the following is the most likely diagnosis? A. Chronic venous insufficiency. B. Congestive heart failure. C. Cirrhosis. D. Lymphedema. Or E. Nephrotic syndrome. The correct answer is E. Nephrotic syndrome. This patient presents with bilateral leg edema, hypoalbuminemia, hyperlipidemia, and massive proteinuria of more than 3.5 grams per day, all of which are hallmark features of nephrotic syndrome. Nephrotic syndrome leads to low oncotic pressure due to urinary protein loss, resulting in fluid shifting into the interstitial space and causing generalized edema, often first seen in dependent areas like the legs. Incorrect choices includes chronic venous insufficiency, since this disease causes bilateral leg edema, but not associated with proteinuria or hypoalbuminemia. CHF is also incorrect, since it typically presents with elevated JVP, pulmonary edema, and other signs of volume overload. Cirrhosis can cause edema and hypoalbuminemia, but typically also presents with ascites and other stigmata of liver disease. And lymphedema is not the correct answer, since this is usually non-pitting and not associated with proteinuria or systemic symptoms. Here's a 52-year-old man presents to the clinic with a 6-month history of progressive bilateral leg swelling. He denies chest pain, dyspnea, orthopnea, or paroxysmal nocturnal dyspnea. He has a history, however, of alcohol use disorder, and he drinks 4 to 5 beers daily. He has not seen a physician in several years. On exam, he has a 2+ pitting edema in both lower extremities up to the knees, a distended abdomen with shifting dullness and scleral icterus. There are no signs of jugular venous distension, rales, or cardiac murmurs. Lab shows an AST of 84, ALT 52, total bilirubin 3.2, albumin 2.4, and an INR of 1.6. Which of the following is the most likely cause of this patient's lower extremity swelling? A. CKD, B. CHF, C. Chronic liver disease, D. Chronic venous insufficiency, or E. Hypothyroidism. In this case, the correct answer is C. Chronic liver disease. This patient presents with signs of chronic liver disease, including history of alcohol use, low albumin, ascites and lower extremity edema, and scleral icterus and elevated bilirubin. The bilateral leg swelling is due to hypoalbuminemia and portal hypertension associated with liver dysfunction. Other options are less likely. CKD, you would expect proteinuria or elevated creatinine, which are not given. CHF, you would expect patients presenting with JVD, rales, or orthopnea, or other fluid overload symptoms, all absent in this case. Chronic venous insufficiency is usually unilateral or asymmetric and lacks ascites or systemic findings. and hypothyroidism typically causes non-pitting edema, not pitting edema. Here's a 45-year-old female presents to the clinic with a 4-month history of bilateral leg swelling. She describes the swelling as non-painful and persistent, not fluctuating throughout the day. She also reports fatigue, weight gain, constipation, and increased sensitivity to cold. She has no history of cardiac, hepatic, or renal disease. On physical exam, her blood pressure is 122/76, pulse is 56, and BMI is 31. Her lower legs show non-pitting, waxy, indurated swelling over the shins with dry, coarse skin. Deep tendon reflexes are delayed in relaxation phase. No jugular venous distension or rales are present. Which of the following is the most likely cause of this patient's lower extremity swelling? A. CHF, B. Chronic venous insufficiency, C. Chronic liver disease, D. Nephrotic syndrome, or E. Hypothyroidism. The correct answer is E. Hypothyroidism. This patient's presentation is classic for hypothyroidism with pretibial myxedema. Key findings include non-pitting edema with a waxy texture, delayed relaxation of reflexes, as well as constitutional hypothyroid symptoms, including fatigue, weight gain, constipation, and cold intolerance, as well as bradycardia and coarse skin. Pretibial myxedema is due to mucopolysaccharide deposition in the dermis, not fluid accumulation, hence the non-pitting nature. Other choices are less likely. CHF would cause pitting edema, but with JVD and other pulmonary findings. Venous insufficiency is often pitting and worse at the end of the day. And cirrhosis and nephrotic syndrome would typically present with pitting edema as well as systemic findings like ascites, hypoalbuminuria, and proteinuria. Here's a 47-year-old female comes to the clinic with a persistent swelling of her right leg for the past 6 months. She denies pain, redness, or recent trauma. She has no fever, chest pain, or shortness of breath. She underwent a right groin lymph node dissection 1 year ago for melanoma. On exam, there is a non-pitting swelling of the right lower extremity, including the dorsum of the foot. The skin appears thickened and firm. The examiner is unable to pinch and lift the skin at the base of the second toe. Which of the following best describes the clinical significance of this finding? A. It is a sign of chronic venous insufficiency. B. It indicates impaired lymphatic drainage. C. It suggests increased capillary hydrostatic pressure. D. It is diagnostic of nephrotic syndrome. Or E. It confirms lipedema. The correct answer is B. It indicates impaired lymphatic drainage. The inability to lift the skin fold at the base of the second toe is known as Stemmer sign, a physical finding suggestive of lymphedema due to impaired lymphatic drainage. Lymphedema can result from primary congenital malformations or secondary causes, such as surgery, radiation, infection, or malignancy. In this case, prior lymph node dissection likely damaged the lymphatic channels. This sign helps differentiate lymphedema from conditions like chronic venous insufficiency or lipedema, which typically spare the feet. This patient presents with chronic progressive non-pitting edema involving the feet and lower legs with firm fibrotic tissue, which is characteristic of lymphedema. Her history of pelvic lymph node dissection increases the risk of secondary lymphedema due to impaired lymphatic drainage. Key clues includes non-pitting edema, involvement of feet and toes, history of lymph node removal, and fibrosis and thickening of skin. A 39-year-old female comes to the clinic with chronic swelling of both legs that has been gradually worsening over the past 3 years. The swelling is symmetrical and painful to palpation, particularly after prolonged standing. On physical exam, there is bilateral symmetric enlargement of the lower extremities from the hips to the ankles. The feet, however, are spared, and there is tenderness to pressure over the subcutaneous tissue. There is no pitting edema. Stemmer sign is negative. Cardiac, pulmonary, and abdominal exams are all normal. Which of the following is the most likely diagnosis? A. Chronic venous insufficiency. B. Lymphedema. C. Lipedema. D. CHF. Or E. nephrotic syndrome. The correct answer is C. Lipedema. Lipedema is a chronic disorder of adipose tissue distribution, most often seen in women, characterized by symmetrical enlargement of the legs, sparing the feet, and associated with pain and tenderness. It is often mistaken for lymphedema, but lymphedema typically involves the feet and is painless. The negative stemmer sign here helps distinguish lipedema from lymphedema. The condition is not due to fluid retention and does not respond to diuretics. A 62-year-old man comes to the clinic for evaluation of bilateral leg swelling that began 3 months ago. He reports no pain, shortness of breath, orthopnea, just discomfort, or recent travel. He has type 2 diabetes and peripheral neuropathy. His current medications include metformin, lisinopril, atorvastatin, and gabapentin. On exam, vital signs are normal. There is bilateral pitting edema of the ankles without erythema or tenderness. Heart, lung, and abdominal exams are unremarkable. There is no jugular venous distension. Lab testings include renal function, liver enzymes, and urinalysis are all within normal limits. Which of the following is the most likely cause of this patient's symptoms? A. CHF, B. Chronic venous insufficiency, C. Gabapentin-induced peripheral edema, D. Nephrotic syndrome, or E. Hypothyroidism. The correct answer is C. Gabapentin-induced peripheral edema. Gabapentin and pregabalin can cause dose-dependent peripheral edema, likely due to altered vascular permeability and vasodilation from calcium channel modulation in peripheral tissues. The onset is often within weeks to months of initiation, and symptoms resolve after discontinuation. This adverse effect is more common in older adults and can be mistaken for systemic causes of edema, but normal cardiac, renal, and hepatic evaluations point towards a medication-related etiology. A 58-year-old man presents to the clinic with bilateral lower extremity swelling for the past 2 months. The swelling is worse in the evenings and improves overnight. He denies shortness of breath, orthopnea, chest pain, or recent weight gain. He is on amlodipine for hypertension and atorvastatin for hyperlipidemia. Physical examination shows a symmetric pitting edema of both ankles and lower legs. No erythema, tenderness, or skin changes noted. Heart, lung, abdominal exams are all normal. Labs including renal function, liver enzymes, and urinalysis are all within normal limits. Which of the following is the most likely cause of this patient's edema? A. CHF, B. Chronic venous insufficiency, C. Amlodipine-induced arteriolar dilatation, D. Nephrotic syndrome, or E. Hypothyroidism. The correct answer is C. Amlodipine-induced leg edema. Amlodipine is a dihydropyridine calcium channel blocker, commonly causes peripheral edema due to preferential arteriolar dilatation without equivalent venodilation, leading to increased capillary hydrostatic pressure and fluid extravasation into the interstitial space. This is dose dependent and not related to systemic fluid overload. The normal cardiac, renal, hepatic findings in this patient points towards a medication side effect rather than a systemic disease. Edema typically resolves with dose reduction. A 64-year-old female presents for follow-up of hypertension. 2 months ago, her primary care physician started amlodipine 10 milligrams due to persistently elevated blood pressure. Since then, she has developed bilateral ankle swelling that worsens throughout the day and improves overnight. She denies shortness of breath, orthopnea, chest pain, or weight gain. She takes amlodipine for hypertension. Blood pressure is 146/94, heart rate 70 beats per minute, and there's symmetric pitting edema of both ankles without erythema or tenderness. Heart, lung, abdominal exams are all normal. Labs, including creatinine, liver enzymes, and urinalysis, are all normal. Which of the following is the most appropriate next step in the management? A. Switch from amlodipine to a beta blocker. D. Discontinue all antihypertensives. C. Add lisinopril to current therapy. D. Prescribe furosemide. Or E. Reduce sodium intake. Here, the correct answer is C. Add lisinopril to current therapy. Amlodipine is a dihydropyridine calcium channel blocker. Frequently causes peripheral edema due to preferential arteriolar dilation without corresponding venous dilation, and therefore increasing capillary hydrostatic pressure and promoting fluid extravasation. This is not due to fluid overload, so diuretics are ineffective. Adding an ACE inhibitor or an ARB causes venodilation, which balances the arteriolar dilatation from the CCB and reduces capillary hydrostatic pressure, thereby decreasing edema. This combination is supported in patients who require ongoing calcium channel blocker therapy for hypertension but develop peripheral edema. Thank you, and this ends my talk on my approach to chronic bilateral leg edema.